All right, let's get started. So first name I see, Dr. M. All right. Dr.
Yes.
M, this question is for you. Let's get started. So here it says, which of the following is most likely to be seen in this patient? All right, so we got to figure out what's going on with this patient. Now, I don't necessarily want you to look at the image first. It's a big image. In the actual exam, you'll expect to get bigger images, but the idea is I don't really want you to look at the image until last, right? Remember, we look at it last to confirm what we are suspecting. All right, let's go ahead. Let's see what we got. We got a 60-year-old man comes in, experienced progressive shortness of breath, worsened over the past year. Dry cough, is that restrictive or obstructive?
Restricted.
Nice. He's unable to climb one flight of stairs without stopping to catch his breath. Extensive cardiac workup includes EKG, echo, stress tests, no abnormal findings. He doesn't smoke, no alcohol, he doesn't party, doesn't do anything. Let's see, labs are fine, vitals are okay, physical exam. Increased convexity of the fingernails, what is that? Increased convexity. Yeah, increased convexity in the fingernails. What does that mean?
Clubbing.
Nice, I'll take it. Clubbing. Yeah, good. Why would anybody get clubbing? Why would that happen?
I think it's hypoxia or something.
I'll take it. I'll take it. Thank you. That's it. That's the first thing that came to mind. Hold on to that. And expiratory crackles are appreciated bilaterally. Okay, crackles, is that restrictive or obstructive?
Restrictive.
Yeah, exactly. For the most part, it's restrictive. Okay, great. So most likely to be seen. Would we see a positive PPD in this restrictive lung disease?
I don't know.
You don't know? Okay. Yeah, PPD.
Oh, okay. Sorry. No.
Okay, no. All right. Would I see elevated intracellular chloride in this patient?
Maybe this happened to the
Does it happen to this patient? Does it happen to this patient?
No.
Okay. See, I don't care who it happens to. Who are we talking about? Focus on the patient. All right, and we're down to two answer choices: elevated hematocrit or elevated was it AST? Do you like A? Do you like B? Do you not like A? Do you not like B?
A.
What about it? You like A or don't like A?
I like A.
Oh, you like A. Okay. Elevated liver enzymes. Nice. Incorrect. Elevated hematocrit. Why? Because what was the first thing you said? I said, why do they have clubbing?
Hypoxia.
Nice. Hypoxia. And in hypoxia, what happens? What else happens? What happens in the kidneys with hypoxia?
Decrease glomerular filtration.
Hypoxia. I didn't say low volume state. Hypoxia. In hypoxia, tissues are saying, hey, where's my oxygen? Maybe there's no red blood cells available. So what do? They send a message. They send a little text or something, right? Read it to the kidneys. Hey, man, what's going on? So at the level of the kidneys, what do you release? Anyone know?
Erythropoietin.
Exactly. EPO. EPO. And where does EPO go to?
Bone.
Bone. And what does it cause the bone to release?
Increase.
Let me give it different colors here.
Erythrocytes and blood cells.
Yeah, red blood cells. We got some white blood cells, maybe some platelets. Okay. But for the most part, the focus is going to be on the red blood cells, you see? And then that leads to an increase in red blood cell distribution width. Okay, increase in red blood cell distribution width, or red blood cell mass, or hematocrit. Okay. Any cause of hypoxia can essentially lead to this. This is known as polycythemia. Okay. Here they gave you a, what was it they say? Idiopathic pulmonary fibrosis? Sure. It's hypoxic. It could have been any obstructive lung disease. Hypoxia, doesn't matter. Okay. EPO, polycythemia. Also remember, now that we're on that topic, renal cell carcinoma, okay, can also release EPO, and Wilms tumor, which is the child's, basically like the child version of renal cell carcinoma, if you want to think of it that way. All right. It can also lead to EPO release and again, polycythemia. So remember that, please. Thank you. All right. Nice job, Doc. Clear, concise. We got it. Elevated hematocrit. Okay. Just hypoxic lung disease. Wonderful. All right. All right. All right. I like it. I like it. Next one. Let's see who we got here. Dr. Douglas. This guy's always popping up. I like it. He's always here.
All
Nice.
right.
All right, Doc. What explains the ineffectiveness? Oof, this is good. This is a good concept of the medication prescribed. So what do we give him and why does it not work? Let's find out. 21-year-old guy comes in, evaluation, dry cough. All right. Is that restrictive or obstructive?
Dry cough, that's restrictive.
We're thinking restrictive. Headache, difficulty breathing. He's heard that one or the two other soldiers, they had something similar. Okay, so we're talking about a soldier, 21-year-old guy, and they have difficulty breathing, and a few other guys in the barracks. Throw out the word barracks. What are we thinking?
Probably like some type of pneumonia.
Okay, good. What flavor of pneumonia is seen in soldiers?
What was
Would it be bacterial or non-bacterial atypical?
non-bacterial typical?
Nice. So now you're thinking amongst your list of non-bacterial or atypical bugs, soldiers, barracks, young guy. They could have also said college dorm.
I could have either. I could probably mycoplasma.
Nice. That's the first one that came to mind. That's what we're going with, mycoplasma. Very good. So maybe it's walking pneumonia. Great. He doesn't use drugs, doesn't drink. He does have a fever, slight fever, right? Not too bad. Respiratory rate, pulse is 92. Okay. Lungs are clear to auscultation. However, chest x-ray shows patchy interstitial infiltrates. Look at that. Interstitial. Is that restrictive or obstructive?
That's restrictive.
Restrictive. So far, it's fitting the pattern. You see the pattern that I kind of gave last time? Okay. First line therapy is administered and he does not improve. So the guy has mycoplasma pneumonia, walking pneumonia. What would you give him?
Azithromycin.
Okay. Okay. And what's the mechanism of action of that drug? Azithromycin. Now, hold on. Before we begin, I'm gonna show you something here. I want to teach everybody something here. Okay. Before you even begin answering, I want to organize your thought process. So let me see if I could type this up. Okay, right over here. So mechanism of action of antibiotics. Now, I actually have this in the, what was it? One of my earlier posts with the hepatitis lab findings. I put antibiotics. I don't know if anybody's seen that. The 3 mechanisms of action for antibiotics, okay? So the first thing is we're going to attack cell wall. We're going to attack the cell wall some way, somehow. The second thing that we do is we're going to attack, and I'm typing this up for you guys to see, protein synthesis. Okay, give me a second. Protein synthesis, and the last thing would be DNA synthesis or replication. Okay, boom. That's the 3 mechanisms of action for any antibiotic. This is a very general way of looking at it, but I'm telling you, you do it like this, it's really going to help you organize this much better. So with that being said, Doc, you said azithromycin, but before you even got to azithromycin, all I had to ask you was this: mycoplasma, does he have a cell wall?
No.
No. So would I give him a cell wall inhibitor?
No.
No. See? So that immediately, anything, penicillin, cephalosporin, vancomycin, gone, immediately off the list. You see? That's the beauty of this. So we go on to that, right? Let's look for that. Production of an enzyme that cleaves beta-lactam structures. Well, is that cell wall?
Yes, that's a
Yes. So boom, out. DNA gyrase? Well, maybe we haven't eliminated DNA. I'm just trying to look for cell wall. Methylation of 20S ribosome. What is that? Cell wall protein or DNA?
This DNA.
Okay, DNA. So we leave it there. Dihydropepturate synthase. What is that? Cell wall protein, DNA.
That's DNA.
Okay. And then what about A? Diala to diala-delac?
That's a cell wall.
Okay, good. Now you said azithromycin. Azithromycin, does he work with protein or does he work with DNA?
It works with protein.
Protein. How many answer choices of the ones remaining mention protein?
2. So it's C and B.
Oof. They mention protein. I see the word DNA here.
Okay.
So we remove this one.
Okay.
And now we're down to 2.
Okay. I'm going with
Interesting.
I'll go with B.
All right, B. He's going with B. Look at that. All right, so everyone, so far, what's happened? You guys, when you don't know, follow technique, please. Bottom answer. It's the second time. It's the second time it's the bottom answer. Okay. We've
Okay.
gone over this. Don't fight it. Don't fight it. Just let it happen. Okay. I've been doing this a
Okay.
long time, trying to show you how to pass a test. All right. So now here's the thing. Let me get this out of the way. Now, when it comes to ineffectiveness, saying methylation of the 23S, okay, good. So we already know how these drugs work. Now, how do I get resistance to any of these antibiotics? So this is how I have it understood, okay, when it comes to resistance. The first thing that you can do is you can alter or manipulate the target of that drug. So I can manipulate the cell wall. I can manipulate the protein some way, somehow, the ribosomes or something like that. Or I can manipulate DNA some way, somehow, right? Like in like A, diala to diala-delac, right?
Okay.
Sounds good. Okay, that's one way. That's one way. The next way, you can metabolize it. The bug can metabolize the drug before it gets to the liver. So metabolism, early metabolism due to the bug. Now, how do I say metabolism? Oh, there's a bunch of ways to say the word metabolism. There's methylation, that's one. Acetylation is another big one. Adenylation is another one. Sulfation, glucuronation, etc. There's a bunch of them. Acetylation is by far their favorite, but
Okay.
either way, I'm still looking for metabolism of the drug early on. Okay. I'm looking for some sort of metabolism of it prior. And then by far my favorite one, this is this is kind of specific to tetracyclines, but it's my favorite one because I relate this to my daughter and having boys over. She's only 2, but I'm thinking, 10 years ahead. So if I come home and there's a boy in my house, I'm going to tell them, get the flux out of my house, right?
Okay.
So I'm going to increase the efflux, get the flux out of my house if they're already there. If they come around knocking, hey, Dr. Lopez, can I see? I say, get the flux out of here. I decrease the influx and I increase the efflux of the drug. Okay.
Okay.
Be on the lookout for that. That's a nice way. That's how I remember it. I'm like, okay. I said I would be that way too. All right.
Okay.
So very nice. I hope everybody got that. Okay. Cool, man. Thank you so much, Dr. Douglas. Killing the game.
Welcome.
All right. Doctora Christie, you're next. Well, if you want to
Okay.
speak. Oh, nice. All right, nice. All right, so we're looking at meds. What medication was prescribed to the patient? All right. So we have 24, multiple episodes of difficulty breathing, no chest pain or palpitations, no nausea, vomiting. She has a history of asthma that she has as a child. Okay. She smokes. She's been smoking for 5 years. Okay. Well, she's young. Labs are okay. Let's see, oxygen sat, physical exam, labored breathing, wheezing. Wheezing, is that restrictive or obstructive?
That's restrictive.
Ooh, strike one, try again.
Um,
Well, if it's not
obstructive.
restrictive, yeah, okay, exactly, right? If it's not one, it's the other one, right? All right. So you would think more of an obstructive issue. Needless to say, the physician gives a medication that inhibits leukotriene production. That's it, leukotriene production to manage asthma. So which of the following drugs inhibits leukotriene production? I started eliminating from the bottom up.
So I'm gonna eliminate
All right,
omalizumab,
omalizumab's gone.
ipratropium,
Ipratropium,
albuterol,
albuterol's gone, and we're down to 2.
and I'm going to pick safirlukast.
Safirlukast. All right, nice. Incorrect. Bottom answer again.
Okay.
Again, guys, I'm telling you, stop fighting it. Stop fighting it. Okay? If you're not sure, what I'm trying to show you here is this a technique. And this technique is you're going to get the answer right whether you know it or you don't know it, because you're going to use everything that you do know to the best of your ability. And you're going to say, well, I know it's not this, or this. Great. So at least you're not left with a 50-50 chance. What I'm trying to teach you is that when you do this the right way, you have like a 70 to 75% chance of getting it right. So far, we've been down to two. All three of them, 100% of the time, it's been the bottom answer. Don't fight it. But now, Xylutin versus Zafry Lucas and his brother Monty, right? The Lucas brothers, los hermanos Lucas, right? The Lucas brothers, Zafry Lucas and Monty Lucas, and then Xylutin. Now, I have a video on YouTube that I would like you all to watch, okay, on the arachidonic acid pathway. It's very important. I want you to remember that arachidonic acid can get broken down into, let me draw this out a little bit here for you, just so you can have a visual here. Arachidonic acid can get broken down into COX and lipox, goes down to these enzymes, okay? And from COX and lipox, what do you get? Well, from cyclooxygenase, you get some prostaglandins. Oxygenase, you get leukotrienes. All right. What do prostaglandins do? They lead to, in this case, just nice and general, vasodilation. So I just say dilation, blood vessels. What do leukotrienes do? They cause bronchoconstriction, so spasm. Bronchoconstriction or spasm. So they're saying the production of the leukotrienes. I'm like, all right, well, then that means if it's the production of them, then I got to inhibit up here, right? That's lipoxygenase inhibition, Xylutin. But if they say receptors, inhibition of the receptors or blockers of the receptors of leukotriene receptors, then that'll be over here. So the leukotrienes will stay elevated, but it'll never make it to the target organ. Okay? So please remember that. And be on the lookout for the patient with nasal polyps who takes aspirin, inhibits COX, and then all the precursors go this way, and then they get asthma. Be on the lookout for that, okay? Yes? No? Everyone? Clear?
Yes.
All right, great.
Yes.
All right, so yeah, and remember the Lucas brothers, that's how I like to call them. Los hermanos Lucas. Be on the lookout for those guys. Okay, next one. Let me see here. Who else we got? Oh, I like this name, Lulu. All right, Dr. Lulu, are you there? You available?
Yes, I am.
There she is. All right. Hey, doctora. All right, doc. Let's see what we got. Here it says ancillary studies for the patient which show which of the following abnormalities. Hey, doc, what does ancillary mean? Mm-hmm. Looks like ancient, right? Ancient, past, I would assume. Okay. Got it?
Yep.
All right, good. So past studies would show which of the following. Well, let's find out. We got a 35-year-old man, chronic shortness of breath has gotten progressively worse over the past several years. He notes that he's become short of breath whenever he walks a few blocks. All right, so they're basically saying he's short of breath. Patient social history is significant for smoking 3 cigarettes per day for the past 4 years. Okay, he's been smoking for 4 years now. Pulse is fine, respiratory rate. All right, we got some wheezing. Is that restrictive or obstructive?
Restrictive.
Oof, strike one, obstructive. Increased work of breathing. Pulmonary function tests reveal increased total lung capacity and residual volume. Is that restrictive or obstructive?
Restrictive.
Again, strike one. Doc, what's going on? It's obstructive. Yeah, you said obstructive once. Don't jump to something else. Lab shows the patient's renal function, BUN is 17, creatinine. Now, I want you to know this is normal. Okay, I think we spoke about this, or I did in one of my videos. That's normal. X-ray is obtained. Now, what we have is a guy with an obstructive lung disease, correct?
Mhm.
That's what we have. All right. And then we look at this and we see an obstructive lung disease, hyperinflated lungs, flattened diaphragm, right?
Yeah.
Okay. So what they're asking here is studies which show which of the following. My question to you is, he has an obstructive disease, but which obstructive disease does he have? Do you have any idea? 35, and smoking for about 4 years now.
Bronchitis.
Bronchitis, maybe. He smokes 3 cigarettes in a day. Well, yeah, he has. Yeah, that's just saying obstructive lung disease. Anyone?
Emphysema?
Emphysema. Nice, emphysema. I love it. Emphysema. Great. So he has emphysema. Here, what they're asking is, oh, who said that? Who said that? Say that, please. Say it again. Who said that, rápido?
I don't think that he could have emphysema. It's too early. He's 35 years old, and
Excellent.
it's only 4 years he has been smoking. Only 2
Exactly.
cigarettes a day.
Yep.
It won't be emphysema. It's too quick.
Exactly. But he has something that looks like, smells like, and tastes like emphysema. He definitely does have an obstructive lung disease. But as you said, this is Dr. Who am I speaking with?
Rosado.
Dr. Rosado. Yes, Dr. Rosado. You are absolutely correct. But yet he does have emphysema. So then you have to ask yourself, WTF, right? It's too early, as you said. He's only been smoking 3 cigarettes. That's nothing. In 4 years, it's too soon. It's too soon. So with that being said, thank you, Dr. Rosado. I go back to Dr. Lulu. Dr. Lulu, what do you think he has then? This guy has emphysema, but as Dr. Rosado said, it's too early. But he definitely does have an emphysema. So what are you thinking? What is this? It is, it isn't? Good question. Any ideas, doctora?
Oh, okay.
Any ideas as to what he may have? I'm not asking for the answer. I'm asking for what is the diagnosis? Because if you don't have a diagnosis, it's going to be very difficult to get the answer. Anyone have any ideas? An emphysema that's not emphysema, but like it is, but like it isn't?
Alpha-1 antitrypsin,
Oh, who said that?
Dr. M.
Killing the game, Dr. M. Why do you say that?
Because this patient presents with emphysema, panancina emphysema.
Mhm.
So
And?
it's not the smoke and liver disease too. So
Good.
it's not going to be the smoking history. It's going to be just the age. They want to distract us with the history of smoking, but
Wonderful.
Dr. Rosado say he's too young.
That's right. He's too young. It's
So
only
I
been a
would
few
think-
years.
Yeah, so I will think of alpha-1 antitrypsin.
100%.
And it's still affecting the lower lobes too, right?
Yes. Oh, it's everything. It's the whole shebang. So with that being said, Dr. Lulu, we now have our diagnosis. Now, can you answer it? Cricket, cricket. All right. Dr. M, can you help us out here?
Yes.
What would you choose then?
Well, I would choose
Which one could you eliminate?
eliminate. Let's eliminate decrease in functional residual capacity
Mm-hmm.
because will increase because it's obstructive disease.
That's great. That's great.
Bronchoalveolar lavage fluid with positive silver stain. That is
Gone.
another thing. Blood pH of 7.30. Option B.
Mm-hmm.
Yeah, we'll eliminate in button answer.
All right, great. And then we have A and A. Bottom answer. Why? Because ASTALTs, doc. Liver enzymes. You said it.
Yeah.
Yeah, liver enzymes. Okay. Remember, this is an inherited disease as well. Okay, inherited disease as well. So when it comes to smoking overall, smoking, I want you to remember, is associated with squamous cell cancer, small cell carcinoma, right? So smoking, small cell squamous. It presents centrally. They'll say somewhere centrally presenting. So like, let me make right around here. They'll say somewhere around the hilum, right over here, centrally presenting, right? Versus peripherally presenting, like a Pancoast tumor way over here. That would be an adeno, not related to smoking. You see what I'm saying? So smoking, squamous, small cell, centrally centrally appearing, and centriacinar emphysema. Centriacinar emphysema. Okay. All the if it doesn't have that S sound, then we know it can't be one of those. So panacinar emphysema, adenocarcinoma, alpha-1 antitrypsin. They don't got that S sound. You see? All right, good. Very good, very good, very good. I feel like there was something else I wanted to mention in regards to this. Liver enzymes, AST. It's hereditary. They may mention his father had it. Nothing, that was it really. All right, thank you, Dr. Lulu, Dr. M, appreciate it. Let's see here. All right, who's next? Who's next? Dr. Ramirez, Dr. C. Ramirez, where you at?
Here.
There she is. Hey, Doc. All right, let's go. Best choice of management for this patient. All right, let's find out. Let's find out. What do we give? What do we give? What's going on with this guy? 18-year-old man comes in, routine. He reports that his brother was diagnosed with TB after hanging out in China. They live together. All right, the patient's worried about developing similar infection. Slight fever. Other than that, labs are pretty good. Lungs are clear. Rest of the physical exam is fine. PPD shows 11 millimeter duration. What does that mean, Doc? Is that good or bad?
I think it's bad.
Sounds good. You think it's bad? Good, I like that. Acid fast bacilli smear are negative. Nice. X-ray is obtained. Do you see anything on the X-ray? Anything suspicious?
No.
Good. So X-ray doesn't show me anything. Culture doesn't show me anything, but the PPD you said is bad. So then, Doc, what would I do? What would I not do, right? Would you reassure? There. You be all right. Right? What would I do? What would you do?
Reassurance. Well, we have the chest.
And the PPD that you said is not good. All right, what about levo? Levofloxacin.
No.
All right. What about isoniazid, pyrazinamide, and rifampin?
No, because that's the whole treatment. And
That's okay. I like that logic. What about isoniazid and pyridoxine?
Yes.
Somebody said yes. What about ethambutol and clarithromycin? Doctora Ramirez. Good. So of the three, which one could you eliminate?
isoniazid.
You're going to eliminate isoniazid. Boom. And therefore, what do we do?
I'm not sure. Maybe the bottom.
Good. Bottom answer. They're going to revoke your license, Doc. You just told me. It was a bad thing. If you get a test that says something bad, and then the doctor says, no, but you'll be all right, just leave. You'll say, what the hell's wrong with this doctor? He just told me I had a bad test finding. And he told me, then he says it's all right. Makes no sense. So there's no way you can reassure. But you're not going to give ethambutol either. And you said you're not going to give the whole thing correct. I agree. You're not going to give the whole regimen. No. But you are going to give them something. You have to give them. Exactly. You have to give him something because it's suspicious. And that's what I want you all to see. He's suspicious. I'm not saying you have it, but that PPD makes me very suspicious because what is the maximum duration that you should have at any given time? Anybody, what is it a normal patient gets?
5, I
About
think.
5. Yeah, about 5. So what does that mean though, by the way, this induration? What's happening underneath the skin? Anyone know?
Type 4.
Somebody said type 4, okay. Hypersensitivity,
Yeah.
which means
Yeah.
which means what?
Lymphocyte.
Cool, I'll take it. So there's a bunch of lymphocytes making just a lot of
Yeah.
inflammatory reaction. So under normal circumstances, it should be about 5-ish, right? No more than that, maybe 3, that's okay. But if it's 0, you don't have it, then that means you have no T cells. Ooh, see that? Immunosuppressed. But if it's greater than 5, that means you have an excessive amount of T cells because something's going on. Okay, and in the event that they ask what type of hypersensitivity it is, very nice, doctor. Who spoke? Who was that? Who said that? Type 4.
Averas.
Avera.
Taveras.
Taveras. All right. Nice, Doc. Great job. So yeah, type 4 hypersensitivity. Great job. Great job. Okay. So far, so good. All right, Doc. Taveras, you're up then. Let's do this. Now I know, let me see this. I know I went over this before with you guys, at least last week. So let's check that out. Check it out, Doc. Which of the following conditions would cause a shift in the oxygen hemoglobin dissociation curve similar to that in this case? All right, Doc. You got this, I believe.
Okay.
You got this. All right, we're looking at a shift. It's going to be to the right or to the left. That's it. It's either right or left. That's all we're doing. Let's see what we got.
Yeah.
85, little old lady. She comes in, low income house, bitter cold January night. All right, so it's a cold winter night. She's found unconscious in the apartment. All right. On arrival, she regains consciousness, but she's fatigued, she's distracted, she's confused, she can't answer and complete sentences. Got it, got it. So she's not well. She's had a bad headache. The neighbor who assists her in care reports that the medications that her medications include metformin and statins, which don't really tell me anything at this point in time. On further questioning, the neighbor mentions that although the building has a faulty heating system, interesting, and the apartment was quite warm when he found her unconscious. So now you should be thinking of something, Doc. What are you
Yes.
thinking right there?
Maybe the heater has a problem, but
I love it.
maybe CO.
I love it. I love it.
Yeah,
You're
CO.
on fire. Keep it up.
Mono.
I'll take it.
I don't know how to say
Okay,
that.
that's fine. I'll take it. That's
Yeah.
good. That's good. On the
Oh.
exam, they're not going to ask you what is it called. As long as you got it, as long as you have the idea, I'm happy about it. On physical exam, findings include a little fever, no lacerations, lungs are clear, heart sounds reveal normal S1, head CT, no evidence, blah, blah, blah. All right. So the guy has, like you said, CO poisoning, carbon monoxide.
Yeah.
Does that cause a left shift or a right shift?
Oh my gosh.
Yep,
I'm
mine
not sure.
too. Ooh, anybody want to help? Call Lifeline. Somebody
Right.
who said
Right.
that? Right shift.
Dr. M.
Carbon monoxide. Right shift or left shift?
I thought it was
Right.
left.
Sure.
Oh,
Right.
ooh, somebody said
Increased
right.
government.
Somebody said right. Somebody said left. Oh, Jesus. Ooh, what is it?
I believe it's left.
What? Who said it? Can you speak louder, please?
Left.
Who said left?
I said.
Who's I?
2.
1, 2, oh. All right, Dr. 1218, A16. Got it. It's a bizarre name, but all right. All right, Doc. You're thinking left shift. Dr. M, you're thinking?
Right.
Right shift. Interesting. Anybody else think right or left?
Right.
Take a vote. That's 2 for right. 1 for left.
And I think left.
That's 2 and 2. Ah, damn it. We're right back to where we started.
I think left.
All right. Thank you, Dr. Rosado. All right. So
Left.
left.
It's left. Sorry.
Okay.
Left is left.
Oh, okay. Now we're going to left. That was funny. You guys are great.
Yeah.
Okay. So we're thinking left shift. All right. So then do we remember the mnemonic I gave you last week that I even put up on Instagram for everything that causes right shift? Do you guys remember that? The ones that were here last week?
The right shift,
Everything that causes right shift. Do you remember that?
cadet.
Cadet. Exactly. Yeah. Good. CADE.
Cadet.
Cadet. Exactly. So CO2, altitude, DPG, exercise, and temperature, right? An increase in any one of these, or, well, which of course, remember, means a decrease in the pH, right? Oops.
Yes.
All right. Would cause a right shift, correct?
Mm-hmm.
Okay, well then what do you think will cause a left shift? Flip the arrows. Just flip the arrows. Don't complicate your life.
The
Don't
opposite.
complicate your
Yeah,
life.
opposite.
Yeah, just opposite. That's it. Don't complicate the life. Just flip the arrows. Boom. A decrease in CO2. Okay. So hyperventilating, right? Maybe he was in the mountains and he went to the beach. Maybe he was doing a lot of exercise and he went into a cold temperature. You see that?
Mm-hmm.
All right, good. So that's it. That's it. That was again, we're just reviewing the same old stuff we've seen before. So then, Doc, with all that being said, we're just looking for literally the opposite. So increased temperature?
No.
No. Increased physical activity? No.
I don't think
Increased
so.
partial pressure? No.
No,
Increase in pH? Or is it
maybe.
or an increase in 2,3 BPG?
No,
No,
pH.
no.
Ah, I see. It has to be the bottom
Yeah,
answer.
it's
That's how
pH.
we do it, guys.
Yeah.
Remember, start from the bottom and eliminate. That's how you do it. Wonderful job. You see, it could have been somebody that was hyperventilating. That's a good one. That's their favorite. Somebody who had a panic attack and they're hyperventilating. And oh, you know, and really
Low
quickly,
oxygen.
yeah, low oxygen. Be on the lookout though for the tingling of the lips. Okay, tingling of the lips associated with hyperventilation, as associated with hypocalcemia. We'll get to that in another lecture. But okay, wonderful. Thank you, Dr. Taveras. Nice, man. All right, this is good. This is good. All right, guys. Let's see who's up. Who's up? Let's see, Doctor. Oh, Vanessa. Let's go. ¿Cómo se va? ¿Se va bien?
Hello, muy bien.
Yes, yes.
Okay.
Nice. Let's do it, Doc. So let's see here. Infant is at increased risk for which of the following? All right. What's going on with this baby? 29-year-old pregnant woman comes in middle of the night, painful uterine contractions, 29 weeks. That's not good.
Mhm.
And she's missed several of her appointments. Obese, in distress, hypertensive, pulse is high, glucose is high. We don't even know she has group B, maybe. Cervix is dilated though. Is that good or bad?
Bad.
What's the maximum dilation once we know, okay, it's ready to go? What's the number we're looking for?
Like 10.
10. So it's very, very close. The fetus is large for gestational age. Can you make sense of that?
Has to do with their high glucose, so probably
Exactly. Killing it. Let's see. Remainder is normal. The patient's admitted to labor and delivery, preterm labor, and he's delivered. All right. So we have a baby who is 29 weeks old. Why is that a bad thing?
we would need surfactant,
Cool. What does surfactant deal with?
inflation of the lungs.
Cool. So if I don't have surfactant,
Mm-hmm.
then what happens to the lungs? As
They
you just
have
said.
respiratory distress in the newborn.
Cool. So literally, which one says that?
Looks like G.
Looks like G. How do I know it has to be that one? Because it went down to G. If it goes past the letter E, we know it's going to be something straightforward. Don't fight it. Nice job, Doc.
Mm-hmm.
Respiratory distress syndrome, because what does surfactant do, right? What does surfactant do? Surfactant, let me show you here. This is the way I like to explain it. Let's say here's my alveoli, okay? Kind of like so. And I have this layer of, now I say manteca, which my Latinos, we know it's just like a lot of like butter, right? Just really, really fatty butter. Now, the reason why we have this fatty butter, right, is because of what I want you to understand is that I have atmospheric pressure over here, atmospheric pressure. And what he's trying to do is he's trying to compress and smash, right, the alveoli. That's his job. But guess what? If I have all this butter wrapped around it, is he going to be able to grab onto it? Nope, he can't. It slips right off. So what does surfactant do? It prevents or decreases the effect, the effect of atmospheric pressure onto the alveoli, and therefore it allows the alveoli to expand or inflate, as Dr. Vanessa was saying. See? So if for whatever reason you're missing surfactant, well, then atmospheric pressure is going to go to town and flatten the alveoli. That's called atelectasis. Or if it's in a baby, respiratory distress syndrome, or if it's maybe an adult, ARDS, okay? So it's all the same story, ARDS, NRDS. This is a restrictive lung disease, okay? Nice job, Doc. Killing the game. I love it. Love it, love it. All right, who's next? Let's see here. All right, Dr. Rosado, you're up, my friend. Let me see. Where am I? There he is.
I'm driving, but
Oh, he's
I will
driving?
try
Oh,
to.
no, because then you crash and then it's like my fault. No, I
I'm
don't want to deal with
listening
that.
to the guys.
It's Thanksgiving, I don't want to deal with that right now. All right, guy. All right, Doc. Dr. Camilo. Hello.
Yes.
Bon dia. All right, let's do it. Goes down to G. Don't fight it. Don't fight it. After confirming the diagnosis, What would be the most appropriate treatment? All right, we're looking for a treatment according to the diagnosis. We got to find out the diagnosis first, and then we treat. We have a 55-year-old woman with pancreatic carcinoma, comes to the ER because of a sudden onset of right-sided chest pain that's worse on inspiration and is not affected by palpation. Diagnosis? I gave this last week.
Sudden supervised chest pain.
That's it.
Okay. Tamponade.
Say it again, Camilo.
Cardiac
P.
tamponade.
Cardiac tamponade. Hold on, Dr. Rosado. I was talking to Dr. Camilo. I know you're driving right now, my friend. Go ahead, Dr. Camilo. Sudden onset of right-sided chest pain. Worse on inspiration. Sudden. This is exactly how I said it last week. Sudden. And it hurts to inhale. Sudden. Which one is it?
Oh my God.
Mm-hmm.
Aortic dissection.
No. Anyone
Oh
want to
my
help?
God.
Because we did this last week. We're in the lungs. Why would you mention aorta? We're in the lungs.
ARDS.
No, not ARDS. That's not
Embolism.
sudden. Who said embolism?
Oh
The
yeah.
student,
It's
the student who was here
delay.
last week, the one that was paying attention last week. That's the one who said it. Very nice job, Dr. M. Very good, very good. A pulmonary embolism. Why? Sudden, and it hurts to inhale. And it hurts to inhale. All right, great. So then, Dr. Camilo, if a patient has a pulmonary embolism, how would you treat?
Heparin.
Sounds good to me. Which one says that one? Oh, right there. Nice job, Doc. Heparin is the drug of choice for pulmonary embolism. Okay.
Heparin.
Yep. Very good. Very nice. Okay. I need you to be able to identify. That was very straightforward. Okay. I mentioned it last week's class as well during physio. Sudden chest pain and it hurts with inspiration. Usually chest X-ray is normal. Chest X-ray doesn't really see anything. Okay. Here, this was, what was it? Why? It was because she had a cancer. Okay, great. So the cancer caused her to become hypercoagulable. All right, next question. What's the battery life here? Excellent. All right, next question. Let's see here. I'm going with Dr. Alfredo. I haven't spoken to you today.
Doing
How you doing, Doc?
good.
Good. Let's kick ass right now. Let's do this. Mechanism. Does this receptor, through which of the following mechanisms does the receptor for this drug act? All right, so first we got to figure out what drug are we talking about, then mechanism of action, then which receptor it deals with. Let's go one at a time. We got a young kid, comes in with his mom, difficulty breathing. She says that her son had been playing outside with his father mowing the lawn when his breathing trouble began. So what are you thinking already?
Asthma.
Asthma, yeah. Physical exam, temperature is not too bad. Blood pressure is a little low. Respiratory rate's a little high. Coughing spells, playful, interactive. The sound on the audio clip, okay, we don't really have to hear the sound just yet, and then we give them a single pharmacologic agent that rapidly improves the condition. So, Doc, if we were to listen to the sound, what would you hear?
Wheezing.
Wheezing. So then do we have to listen to the wheezing? Not really, because we already have our suspicion, right? So be on the lookout, guys. Sometimes they'll give you, I'm not even kidding, I saw like a 45-second video on Parkinson's. They were just going through some physical exam findings, and I kind of like or some maniobras, and it was 45 seconds. The whole vignette gave you that was Parkinson's though. 45 seconds wasted. So remember, if you think if the vignette gives you enough information, just go with it, run with it. So Doc, you're thinking asthma. So then what would I give him? Something that would rapidly improve his condition.
Probably something like albuterol.
I'll take it. Albuterol, mechanism of action.
I know it has to do with probably I'll rule out D.
Okay.
E. I'm not quite sure. It's a beta agonist, so
Okay, so beta agonist, I'll take it. So let's start there. Beta agonist. Beta 1 or
Yeah.
beta 2?
beta 2.
Beta 2. Okay, good. So now beta 2, is beta 2 associated with GI, GQ, GS, or a G or adenosine? Is he associated with any Gs or adenosine?
I believe it is a G.
All right, he's a G. I'll take it. Now, GI, GS, or GQ, which one could you eliminate?
Um,
You're thinking B2. And you're like, one of them, I just don't like you. B2.
I will rule out A,
B2.
GI.
A is gone. A is gone. Now we're down to 2, Doc. Activation of GQ or GS? What you thinking?
Sure, so I'll go with the one below.
All right. GS, great job. It is GS, okay? It is GS, very good, very good. So I'm just gonna show you something here at the bottom. I want you to see this page here so you can follow me here. Well, I hope they give you the page. If they don't give you the page, then that's fine. Let me see. In general, yes, excellent, excellent. Okay, good. So in regards to these receptors, let me fix this here. In regards to these receptors, what I want you to first notice is how the GIGS have all the A's, right? A, adenylate cyclase, ATP, cyclic AMP, protein kinase A, okay? That's all associated with sympathetic activity. Versus, all right, GQ. Now, they don't mention it here, but I want everybody to pay attention closely. It has an E sound. GQ has an E sound. So with GQ, we have phospholipase C. Phospholipase C will break down PIP. It'll break down PIP into 2 things, IP3 and DAG, and then that will eventually stimulate protein kinase C. And of course, I remember the C stands for calcium. Everybody got that? Versus A, adenylate cyclase ATP, cyclic AMP, protein kinase A, and E. Now, how am I supposed to remember which receptors go to where? The MAD2s, this mnemonic. People who are too mad to inhibit themselves, I think that's stupid. I don't like it. But guess what? To be mad, is that a good thing or a bad thing?
Bad.
It's a bad thing. You don't want to be mad, right? It's holiday time, right? So it's a negative thing. So done. They say MAD2s. I know that that's associated with inhibition GI. It's a bad thing. See? So boom. M2, alpha 2, D2, done. Inhibition. Of what? Of the AAA ones. See? All right, good. Well, then what about the have one M&M? This one has confused me for a long time, up until I saw, there was this video, Doctors in Training, long time ago, many years ago. They said cuties, like a cutie pie, like a little baby girl, like my daughter, right? She will have one M&M, this little cutie pie. So cuties, cute little girls, or I don't know, there's these little oranges my kids like. I don't know, it's nice. Small oranges, small people, it's cute. So cuties, like GQ, cuties have one M&M, and that's it. H1A, alpha 1, V1, M1 and M3, or MAD2s. If it doesn't fit that, by default, it's GS. Beta 1, beta 2, sure. You see, Doc? That's it. Cuties have one M&M. MAD2s, that's a negative thing. Anything after that, by default, GS. Okay?
Okay.
All right. Wonderful. I hope that helped everybody, because this is super important. Super important. And then it would be also helpful to go over this little amount of kiss and kick until you're sick of sex. All right. So please remember that. That's a good one too. All right, docs. Thank you so much. Let's see who else we got. Who else we got here? Oh. Thank you, Dr. Alfredo. All right. Let's go. Let's see here. Let's go back to Dr. Let's see here. Where was she? Dr. M. All right, Doc. Let's do this.
No. Yes.
All right.
Oh my God.
Which of the following is most likely finding on pulmonary function test?
Mhm.
All right, most likely finding on pulmonary function test. Let's see what we got.
Mhm.
Just got to recognize is whether or not this is restrictive or obstructive. That's all it is. All right, let's see what we got. So 67-year-old man, let me bring this lower here. I'm sorry. 67-year-old man comes in, trouble catching his breath. Symptoms are exacerbated on exertion, and his condition is has been worsening. hypertension, hyperlipidemia, diabetes. He smokes lisinopril, hydrochlorothiazide, and metformin. So far, all I have is an unhealthy 67-year-old man.
Mhm.
Cardiac stress and echo reveals an ejection fraction of 65. Is that good or bad?
It's low.
Ooh,
Hmm?
that's actually wonderful.
Wonderful. It's
Oh, yes.
above 50, right?
Yes, above 50.
Okay. Okay.
Yeah.
Okay. Sorry.
So
It's
good.
good.
65. This is good. This is good. That
Mhm.
means he's pumping out blood as he
Mhm.
should be. All right.
Yeah.
However, the mean pulmonary artery pressure is 35. In addition, he is short of breath after achieving 85% of his maximal target rate. His symptoms are relieved when they give him impratropium, but he has no response to albuterol. Oh my goodness. So what does he have? What type of disease is this? Restrictive or obstructive?
Obstructive.
Obstructive. All right, doc. In obstructive, which one will you attack first? FEV1, FVC, the ratio, or TLC? Which one would you go with first in obstructive? The easiest one for you.
The ratio, maybe.
Okay, higher, low, or normal?
In obstructive, low.
Low. Okay, so it's not A, it's not C, it's not D. See that? Not A, not C, not D. We're down to 2. That's it. We're down to 2. So is it B or is it E? So then what else can you go with?
Let's
Oh.
go.
FEV1 is the same here. TLC is the same.
B.
So it boils down to FVC. The FVC is either going to be high or low.
The FVC.
FVC, yeah, you see that? It's
It's
either
going
B
to be low.
or E. It's going to be low. Okay, so then therefore your answer would be? Don't get confused. What did you say the FVC was going to be?
Degrees.
Okay, so therefore your answer is?
A. No, sorry.
Between B and E. Thank you.
Sorry.
All right. See that? Overthinking. Very good. In obstructive lung disease. You see that? FVC is low, FEV1 is low, the ratio is low, and TLC is high. Okay. Very good. Very good. Very good. Nice job, Doc. All right. Let's see here. All right. I want to see Dr. Douglas again for number 11.
right.
Let's see here.
Okay.
Perfect timing. Yeah, I wasn't sure of putting 10 or 12 questions. I'm glad I put up 12. So, all right, Dr. Douglas, let's get it in. Let's see here. The patients at increased risk of developing which of the following complications? All right. Let's see what we have. Little kid. Okay. So it can only be so many things. The child comes in, fever, pain in the right ear. Pain in the right ear. He states that he's been tugging at the ear for a few days now. He has a fever. He's been tracking 75% percentile, so he's growing pretty well. Recurrent sinus infections. So we're back to the sinuses. Mother's pregnancy was okay. We have a bulging tympanic membrane. What is that right there? Diagnosis?
Otitis media.
Otitis media. So we got a kid with otitis media. Vital signs. He has a little fever. Blood pressure is a little low. Okay. Okay. Heart sounds are not appreciated at the pulmonic, tricuspid, or mitral position. That's bizarre. And regular rhythm are auscultated in the aortic. Okay, so we can auscultate aortic. Lungs are clear. Interesting.
Okay.
So what do you think he has? A restrictive or an obstructive lung disease? Well, you said otitis media, right?
Mm-hmm.
Okay, what type of bug gives you otitis media? First thing that comes to mind. First bug that comes to mind.
Strep.
Thank you. Strep, is that a bacteria, a virus, a fungi, an atypical?
Bacteria.
Nice. And bacteria, is that more restrictive or obstructive?
Bacteria is more restricted.
Oof, obstructive.
Okay.
Obstructive,
Okay.
obstructive. Yeah. All right, good. So we're thinking an obstructive lung disease. Cool. But what gets me is what's highlighted in pink. What does he have, this kid? Recurrent sinus infections. It's an obstructive lung disease. And for some reason, what do you think he has? So very good question. Very good question.
Yeah, molecular mimicry.
Who said that? Molecular mimicry?
With the strep protein?
Looks like Carter-Jenner syndrome.
Oh, Carter-Jenner syndrome. Nice. Hey, Dr. Douglas, do you see?
Dextrocardia.
Nice. Dr. Douglas, did you catch that?
No, I didn't.
Oh man, but look, it says the heart sounds are not appreciated
Mhm.
where they're supposed to be, but for some reason the aortic is.
Dextrocardia.
Dextrocardia. Yeah. Got it? Situs inversus. Well, all they're trying to say is that the heart is not where it should be, and that's it. They're not. They maybe it would have been nicer had they said the mitral valve or whatever the heart sounds are auscultated on the right side. Had they mentioned that, it would have been a little bit easier. Here they're saying it's not on the left. Okay, well then where is it? Well, it's on the right. You see?
Okay.
That's all it is. I'm not in the bathroom. Like, yeah, okay, well, where am I? Oh, I'm in the office. Oh, okay. You see what I'm saying? It's like that's what that I don't like when they do that. It's not a lot of things. It's not a lot of things, but okay. Anyways, that's the idea. Okay, that's how they play with these questions. All right. So don't ever think that, oh, I don't know this. You do understand this information. If you study, you plant the seed, you cultivate the seed, you will reap the harvest. Okay.
Okay.
So, Doc, he has an obstructive lung disease. You know what? Doesn't even really matter which disease he had, although I am glad that you figured out it was Carter-Jenner's. But regardless of the fact, he has an obstructive lung disease. So with that being said, what is he at increased risk of developing in Carter-Jenner's or an obstructive lung disease? Would it be pancreatic insufficiency in Carter-Jenner's?
No.
No. Mitral regurg?
No.
Heart failure?
Maybe.
What about failure to thrive? What about emphysema? What about bronchiectasis?
No.
Hello? All right, good. So you see, normally, when you find yourself in this situation, let's say it's the day of the exam, you're going about your questions, and this is question 11, you're just beginning the test, an MB, whatever it may be, and you're unable to eliminate, which notice, we've been able to eliminate with each and every question. This is the first time we can't really eliminate that well. What do? I want you to mark it and choose an answer. I'm not going to choose an answer because it'll tell me whether it's correct or incorrect, but you choose an answer, you mark it, and then you go on to the next question, and then you come back a little later. Okay, you come back towards the end of the block to check it again. The idea is not to linger and waste time. Okay. You just kind of try to figure it out. If I can't rule out anything, that's it. Just move on forward. Then you kind of come back and you try it a second time, maybe even a third time if you have enough time to do that. But now we come back. Now we can actually help. We can ask somebody here for help here. We're thinking Carter-Jenner's. So increased risk of developing which of the following? What can we eliminate, or what do we think the answer is?
The answer would be bronchiectasis.
Bronchiectasis.
Bronchiectasis, sorry.
Nice. I like that. So not heart failure, not failure to thrive, not emphysema, but bronchiectasis, which is something that classically occurs in many obstructive lung diseases. It's not just specific to Carter-Jenner's. It could easily be seen as cystic fibrosis. Okay. Doesn't just have to be one. But all in all, I do want you to remember bronchiectasis. They wanted you to specifically know Carter-Jenner's, and they wanted to confuse you with cystic fibrosis. Okay, because in cystic fibrosis, they can get the pancreatic issues. Right? Very good. Yeah, that's a good one. Always be on the lookout for the heart sounds. I've seen them. I mean, they said everything is normal. Heart sounds are located well auscultated, and they said at the 5th intercostal space on the right, and then they kind of like threw the word right, kind of like dead center. And if you read it really quickly, you kind of think left, and that's the issue there. So be on the lookout. All right, cool. And let's see here. Last question. I want Dr. Taveras. Let's see here, Doc. Is he there?
Yes.
There he is. All right, Doctor. Let's do it. Kick ass here. Which of the following risk factors is associated with the development of this condition? What condition are we talking about? Let's find out. And we're looking for a risk factor. 6-year-old guy, chronic cough, difficulty swallowing, new onset of voice changes. Okay. In the recent months, he's had fatigue, weight loss. What are we thinking right there? Just when they say that.
Oh, maybe cancer.
Cancer,
something like
thank
that.
you. Yep, so we're thinking some sort of cancer. He reports postprandial indigestion while lying down. He's a rock singer. He smokes more than his share of alcohol, so he drinks also. That's fine. He's had unprotected sex with multiple partners. All right. The patient is found to have a mass arising from the left true vocal cord. Biopsy shows neoplasia. Doc, what do you think he has? You said it.
If
You said cancer.
cancer in the esophagus, esophageal cancer. something
Nice.
like that.
I'll take it. Is it associated with untreated H. pylori infection?
I don't think so.
Good. Is it associated with smoking?
Maybe.
Maybe. What about HPV? Type 6 and 11. What about reflux?
Reflux.
GERD. Reflujo.
Oh my God.
All
Good.
right. Oh my God. What about
Yeah, I
chronic
know, but,
irritation? What about chronic irritation from singing? What about that one?
I don't think so.
All right. So of the 3 remaining, which one could you eliminate? Risk factor for esophageal carcinomas, you said. Which one could you eliminate?
I will eliminate the C.
C is gone. We're down to 2, Doc. Is it
Yes.
GERD or is it smoking? What you thinking?
I would put D.
B. B or D? Well, it's bottom. It's D. D. Okay, that's fine. D. That's fine. I
Yeah.
misunderstood. That's fine. These damn letters, right? Very good. Smoking history, right? Bottom answer. It was smoking history. It causes esophageal carcinoma, etc. Okay. Not so much GERD. HPV can also lead to, some findings in the true vocal cords. But which serotype? Do you remember? Anyone?
18 and 16.
Excellent job, Doc. Okay, that was nice. That was a very good class, guys. It's 1 o'clock. It's Sunday. I appreciate you guys for coming out.